Our topic of discussion in these slides is going to be the general management of allergy. So we know we have a patient with allergy. We've diagnosed them with allergy, be it allergic ophthalmitis or allergic rhinitis or atopic dermatitis or just seasonal allergies with symptoms. Then that's great. How do we go about managing it? And the way we manage a patient with allergies is two-pronged. We want to reduce their exposure to the allergen, assuming we know what it is, and that should be part of our diagnostic paradigm, is to figure out what the allergen is, either via history or formal diagnostic testing, like skin testing. And then, if that's not enough, and usually it's not enough, just to simply avoid exposure to the allergen for reasons we'll talk about, then how do we manage their symptoms? In a lot of cases, patients will be doing something to manage their symptoms because there are so many drugs that are available over the counter for allergies. However, there are drugs in our arsenal that are not over the counter that we can prescribe if over-the-counter drugs and exposure reduction is not enough. So we're going to talk about exposure reduction and pharmacologic therapy here. So what do we do to reduce the patient's exposure to allergens? That's going to depend on the allergen involved. Now, this is why it's important to identify, at least via history or via formal diagnostic testing, identify the allergen that's involved. Now, a lot of times you can surmise what the allergen is based on history. If a patient lives in a northern climate and it's seasonal allergies, comes on in April, May, June, and then remits by October, then it's probably seasonal allergies, and it's probably something outside, pollen, trees, weeds, something of that nature. If it's year-round, on the other hand, then it's more likely to be something indoors, so house dust mites or pet dander or cockroaches or mice or something of that nature. So assuming that we know the allergen involved, there are various things that we can counsel the patient, things that they can do that can minimize their exposure. Now I say minimize, not obliterate their exposure. And the reason is because it is impossible, outside of living inside of a bubble, it's impossible to have no exposure to allergens. There have been studies, even in ICUs, which we try to maintain a nice sterile environment, even in ICUs, there's appreciable, substantial amounts of pet dander in ICUs. Why? Well, the answer is quite obvious. People come from outside of the ICU, they track in their cat dander from home, and it stays there. And the stuff is the cat dander is very light. And I'm just using cat dander as an example, but certainly this can apply to other things as well. But it's light, it stays in the air very easily, it's difficult to filter out, and so it's very easy to track allergens into other environments. Okay, so how about house dust mites? How can we avoid exposure to house dust mites? Now, it's not the dust mites, it's not the mites themselves that are the problem, it's their feces. That is the allergen that causes symptoms. Now, dust mites are very, very, very hardy little buggers. They like to congregate in areas where people are. They like us. And the reason they like us is because they eat our skin cells. They don't eat our skin cells while they're on us. They eat our skin cells after they've sloughed off. As you know, we slough off skin cells, dead skin cells, that then collect as dust. If you ever brush dust off of your table, that's what that is it's carbonaceous material, and that includes scales of skin that have been shed. And dust mites eat that. That is their food. And as they eat that, then they also excrete waste products, and that waste is then what we are exposed to and that we are allergic to. So anywhere where we congregate or where we spend time, where we lay down, where we sit down, that's going to be places where dust mites are going to thrive because our skin cells are there. So when you think of what's the one place you spend more time than anywhere else, it's your bed. and your bed is going to be a place where there are plenty of mites. And so one of the ways that you can reduce your exposure to dust mites is to do two things. First of all, encase bedding that you're not using in an airtight or allergen impermeable cover. Now, there are a couple ways that this can be implemented. You can remove your bedding after you're done using it and put it into an airtight cover, and then just replace it when you're ready to go to bed. And then this can also be applied to bedding that you're not using. So rather than just crumpling up your sheets that you're not using and putting it into a closet, you can put it into a hypoallergenic case, which then will reduce the amount of dust mites that are on that, because they're not going to be able to thrive because there's no oxygen. So there's two ways that you can apply that. Secondly, wash your bedding weekly. So bedding should be replaced and washed every week. It's really disgusting, but there are people who will go months on end without replacing their bedding. And when you think about it, the longer and longer and longer that you have your bedding on your bed and you don't replace it, the more dust mites are going to be able to proliferate. So you want to wash your bedding every week, preferably in a washing machine with water, with temperature more than 150 degrees Fahrenheit. That will kill the dust mites. These are, like I said, very hardy creatures. They've adapted to survive in very harsh environments. Next, remove all wall-to-wall carpeting. Now, this is where we start to kind of get into what's practical and what's not. And you have to tailor your advice to the patient. Understand that they're not going to be able to do everything you tell them to, and not all of these recommendations are practical. Removing carpet, if you live in an apartment, for instance, your landlord might not allow you to do that. Or if you're in a house but you don't have the money, replacing carpet with linoleum or hardwood floor is not always financially feasible. But if you do have the means, removing carpet is good. Why? Because mites thrive on dust, and dust is going to be inside the carpet. Even if you vacuum, you can't get all the dust out. And so even if there's minimal amount of dust, the mites can thrive there. On the other hand, if you have hardwood floor, it's much more difficult for dust to collect. Replacing curtains with blinds. Again, linens hold dust. Dust is food for house mites. So if you can replace it with blinds, they make like wooden blinds now. Those are good. Remove upholstered furniture. Again, same thing around carpeting and bedding. The fabric on furniture can harbor dust, can harbor skin cells. So if you can remove that or minimize the amount, then that's preferable. Now, again, you run into how practical is this. Certainly, no family is going to want to have wooden furniture everywhere, and so in that case, what you can do is they do make these hypoallergenic sheets that can go over furniture. That can be useful. Another thing that you can do by having those sheets, you can then wash it every so often, periodically, and that's going to be a lot better than having just regular old furniture where you have dust and you've got stuffing inside the furniture that can provide a habitat for mites. And then another way that you can get rid of house dust mites, or at least minimize their population inside your home, is to reduce indoor humidity. And this is going to be good for fungus and mold too. If you reduce the humidity, the relative humidity, to below 50%, you can do this by getting a dehumidifier, then these dust mites are not going to be able to thrive as well, because these mites, they breathe and they drink through their skin. And they get their fluid by essentially breathing in humidity. So if you reduce the indoor humidity below 50%, it's going to be very difficult for these mites to survive, because they do require getting their water through that means. Okay, how about pet dander? The obvious solution, be it cats or dogs, is to remove the pet from the home. Not always practical. A lot of patients are going to say, no, I can't get rid of my pet dog. So what can we tell them? Well, there are ways that you can minimize your exposure. So for instance, let's say it's a child. There should be pet-free rooms in the house. So the first most obvious solutions, make sure that the pet is not in the child's bedroom. Remember, anybody spends most of their time in their bedroom. Even though it's not your waking hours, you spend most of your time in your bedroom. So the pet should not be in your bedroom. And then any room where the pet spends, or where the child spends a lot of their time, so playrooms, pet shouldn't be in there. So having these pet-free areas can be useful. Again, you're minimizing exposure. You're not going to be able to completely obliterate your exposure to these allergens, but minimize exposure. Along the same lines as with the house dust mites, if you can remove carpet and upholstered furniture, that can be useful as well. And that's just because the allergen can settle in these areas. So if the pet is laying on furniture and then the child goes and lays on the furniture, you can get exposure that way too. Now, one thing that pet dander has that we don't see with the house dust mites is that pet dander and that FeLD1 protein, these are very light allergens. They're very, very small. And so because of this, they are in the ambient air more than the fecal matter from the house dust mites, which tend to be settled on surfaces. So because they're lighter and they circulate through the air, you can get these HEPA filters, and HEPA, I believe, stands for High Energy Particulate Air Filters, HEPA. And what this does is it filters the allergen out of the air and then recirculates that air. And so you're essentially vacuuming out the allergen out of the air. And these HEPA filters can be useful. You have to look at the consumer guidelines and everything, but there are approved HEPA filters. I'm not an expert in this area, but these can be useful for patients. Okay, this is a house dust mite, just to give you an idea. It's disgusting. It looks like scabies, and in fact, it is related. It's in the same class, Arachnides or something, but the same class as scabies. So very gross, 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 gross. Luckily, we don't see these things, but believe you me, they are everywhere. They're probably crawling on you at this very moment. I'm not kidding. Okay, cockroaches. So cockroaches aren't a problem that a lot of people have, but some people do have problems with cockroaches in their homes. We see this more so in older homes. So you can expect to see a potential for cockroach problems if you work in inner cities, places where there's a high number of older homes, older than 50, 60, 70 years old. And the reason is because as houses get older, they fall into disrepair. You can get things like cracks in the floorings and walls, and you can get problems with leaky pipes. And what this does is, within the walls, you've got a nice dark environment for the cockroaches. Leaky pipes provides them with hydration, and so this allows the cockroaches to get inside the house from outside and then to thrive within the walls or in the attics. So just these basic household maintenance things can be useful. Putting away food after use, they eat crumbs. So if you put away food, clean up, frequent cleaning of the house, that can be useful too. Okay, what about fungi and mold? So here we're talking about indoor fungi, but also outdoor fungi too. So don't use window unit or attic fans. So if you've ever been in an older apartment or an older building, you'd see that a lot of them are not retrofitted with central unit air conditioners, and so a lot of them will have window units or fans. All that serves to do, while it does cool you down a little bit, it also serves to blow whatever's in the ambient outside air inside the closed area of the home. And so you can get exposure to outdoor allergens that way very easily. So on that note, it's useful to keep the windows sealed, use an air conditioner. A lot of air conditioning units and indoor, my dad works on these professionally, but ventilation systems, they'll have filters that can filter out some of those outdoor allergens. Dry laundry in a dryer. Why would you want to dry laundry in a dryer? Well, what's the alternative that we used to use before that? We used to use clothes, like outdoor clotheslines. And some people still do that. My mom actually still did this up until I was a young kid, because we live in a kind of a rural area and we had the room for it, and it saved on the energy bills. Well, problem again here is that if you live in a rural area, you probably live where there's a lot of weeds and trees and pollens, and all of that stuff is going to collect on your clothes. And so when you put the clothes on, then now you're exposed to allergens. Whereas if you dry your clothes in a dryer, you're not going to have that. Frequent hand washing. Again, you go outside, there's allergens outside, then it's going to get on your hands. Then what do you do with your hands? A lot of times you rub your eyes, rub your nose, rub your face, and so you can get exposure that way. So washing of the hands is useful, especially after coming in from outside. And then before bed, you should always shower and shampoo. You should do this anyway, but shower and shampoo before bed or after coming in from outside, where there may have been exposure to the allergen. So a lot of times what you may run into is a patient who goes and mows the lawn or goes out for a jog around a park where there may be weeds. You might want to counsel that patient to take a nice shower and wash down after they come in. All right, so now we're going to turn our attention to the pharmacologic agents. There are so many of them. And this is just a testimony to the fact that allergies are such a problem. For so many people, there's a high demand for allergy medications. And you see this all the time on TV, with all these new allergy medications that are coming out. It's a billion-dollar industry. And it's really a good thing because we can always use more allergy medications. Because this is such a problem and it impacts quality of life, and it even causes people to miss work or be less productive at work or less productive at school, and it really costs us in the long run. And so we have a lot of pharmacologic agents. Some of these are old, tested, tried and true. Some of these are cutting edge. All right, so let's look at the first class. This is the adrenergic agonists. A lot of these are available over the counter. So remember, going back to physiology, that we have adrenoreceptors. These are all responsive to epinephrine, so the sympathetic nervous system will trigger all of these. But what we're looking at when we're concerned about allergy is the alpha-1 receptors and the beta-2 receptors. So if you look at what these do, you can see, you pause it and try to pick out what's important here when we're talking about allergy, but it's vasoconstriction, which leads to increased permeability and well, if you have vasodilation, but vasoconstriction and then bronchodilation. So what we're using here are agonists. It's not antagonists, not like beta blockers or alpha blockers. We're using agonists. So an alpha agonist is going to cause vasoconstriction. And this is good because this inhibits or reverses the effects of histamine. Remember, histamine causes vasodilation, and that allows fluid to permeate into the tissue and cause swelling. So with an alpha agonist, in addition to other symptoms that you can get as side effects, you get vasoconstriction, and that counteracts what histamine is doing, at least on the vascular level. Now with the beta-2 agonists, which primarily we use in asthma, the main effect here is going to be bronchodilation. And again, this is useful because when you have exposure to allergen, you get bronchoconstriction as one of the symptoms, and that's due to mast cell destabilization and degranulation. So when you activate the beta-2 receptor with a beta agonist, you get bronchodilation, and that will reverse that. So you can see a lot of things that these adrenoreceptors do. We're really focused in on a couple of these things when we're looking at treating allergy with adrenergic agonists. So first, so I already told you, alpha-1 and beta-2 are the receptors we're concerned about. So the first we're going to look at are the alpha-1 adrenergic agonists, and these are primarily over-the-counter medications, including Sudafed and phenylephrine. So these are readily available over the counter. A lot of times now in the US, you have to go to a pharmacist and they have to actually dispense this to you, but it is still nevertheless available over the counter. Phenylephrine is a little bit easier to get. Typically, you can just bring this up to the cashier and buy this yourself. What they have in common is that they are both alpha adrenergic agonists, alpha 1 adrenergic agonists. And Sudafed is a little bit more, it's a little stronger than phenylephrine, but they both do the same thing. And they cause vasoconstriction, which abates the effect of histamine, which, remember, histamine is a vasodilator. And so by doing that, they work to decongest. And you hear these referred to by the laity as decongestants, and that is what they are. They are decongestants because when you have histamine working to dilate arterioles and venules, that allows fluid to move out. When that fluid moves out, the tissue becomes edematous and congested. And so by having vasoconstriction, you reduce the amount of fluid that can move out, and you can then drain that edematous fluid and abate the congestion. This is a treatment of choice in allergic nasal disease, as we're going to see. Now, I put these two that are taken as pills, and certainly they can be taken that way, and that helps with nasal congestion. But you can also get these alpha 1 adrenergic agonists in the form of nasal spray. Now, that, on the other hand, can only be, I believe, you can only get that with prescription. I'm not aware of any over-the-counter nasal decongestants that you can get that are the spray. But with the spray, it's a lot more effective because you're applying it topically. The problem with the spray is that it's so effective, patients will overuse it, and you can, when you stop using it, you can get a rebound rhinitis. They call that rhinitis medicamentosa. And that's just rebound rhinitis, which you can get from overuse of nasal decongestants. However, typically you don't run into that problem if you take it orally as recommended. The adverse effects here with the oral medication is going to be excitability, headache, nervousness, palpitations, tachycardia, hypertension, nausea, vomiting, urinary retention, arrhythmia. If you go back here, look at what the alpha 1 receptors do. They cause vasoconstriction, increase peripheral resistance, increase blood pressure, mydriasis, increase closure, internal sphincter of bladder. So all of these things, adverse effects of adrenergic agonists. But you do get that vasoconstriction, and that is desirable when you're treating allergy. An adverse effect, as I mentioned, with the nasal spray is you can get that rebound rhinitis. Whoops. Okay. So how about the beta-2 agonists? These are primarily used in the treatment of asthma. So the beta-2 agonists, there's so many of them, but the ones that are most commonly used are, well, you can divide these up into short-acting and long-acting. And the short-acting beta agonist that's used most commonly is albuterol. So albuterol is a mainstay of therapy in asthma. That's what you use as your rescue inhaler. It works very quickly. Its effects don't last very long, but it's useful for patients with acute allergic attacks, acute asthmatic attacks. The other subset of beta-2 agonists are the long-acting beta agonists, and these are used mostly in maintenance therapy for asthma. So these are things like salmeterol and formoterol. These are never used by themselves. When these are used by themselves, it has shown an increased risk of adverse asthma-related events, including death. And so typically we will use these with an inhaled corticosteroid. So you'll see this, like for instance here in Advair, you have salmeterol, but you also then pair that with fluticasone. Now these are beta-2 agonists. They're selective for the beta-2 receptor, not just the beta receptor, the beta-2 receptor. Now there are medications that are non-selective that work both on beta-1 and beta-2. Remember back to cardiac physiology, that would be things like epinephrine or isoproterenol. And then there are things that work specifically on the beta-1 receptor, which would be things like dobutamine. Now, we're focused here on the beta-2 receptor. The beta-1 receptor is primarily in your heart and kidneys. The beta-2 receptor is pretty much everywhere else. So we want to focus in on the beta-2 receptor. Would a non-selective beta agonist work? Yes. If you were to give a patient epinephrine or isoproterenol, it would abate some of their symptoms of allergy. However, it would have the adverse effect of of affecting their heart as well, and that we want to avoid, so we use specifically beta-2 agonists here. Adverse effect here, you really don't run into a whole lot of problems with a lot of these, but you can get tremor, palpitations, tachycardia, a lot of these sympathomimetic effects. You can also get hyperglycemia, hypokalemia, hypomagnesemia, and that's just due to the fact that this does have some effect on cell channels. And then transient hypoxia. This is transient. Typically, we don't see any manifestations of this clinically. The reason is because when you're using, let's say, albuterol and you inhale it, it does cause enough vasodilation to where you wind up aerating dead parts of your lung that don't get very much circulation. And so it reroutes some of that air into areas of the lung where there's not as much circulation, so there's going to be a VQ mismatch to a certain degree. But this is transient, so you don't really have to worry about this. This is just a physiologic manifestation. All right, what about the anticholinergics? Primarily, the anticholinergic that we use is ipratropium. Ipratropium is marketed as Atrovent, and you'll see this used as an inhaler. It can be used by itself, or it can be combined with other agents. So the way this works is quite straightforward. It blocks acetylcholine at muscarinic receptors. Remember that the vagus nerve will cause things if it fires, such as vasoconstriction, vasodilation, and bronchoconstriction. And so if you can block this, then you can get away from that. The most commonly used, as I mentioned, is ipratropium, and that can be used either as an inhaler or as a nasal spray. So I have both of them here. Really, this is never a first choice when managing anything. It's usually used as an adjunct, or it's used as something in combination with something like a beta agonist or a steroid. Okay, antihistamines. This is the major class of medications used for allergy. So you see all sorts of antihistamines and all different kinds of preparations, ophthalmic preparations, nasal sprays, topical ointments, oral preparations, even IV. So you see antihistamines all over the place. And antihistamines as a whole exerts its effects by reversible inhibition of the various histamine receptors. We are focused on the H1 receptor when we're talking about allergy. Now, another class of antihistamines, the H2 inhibitors, that we use for things like gastric reflux or ulcers, where the H2 receptor is primarily implicated in stomach acid. And so those are sort of your antacid drugs, whereas with the H1 receptor, when we target that, we're focused on allergic disease. So this is widely used in the treatment of allergic disorders. Its half-life will vary, but it doesn't really matter because these antihistamines, what they do is they will accumulate in tissue and then can be reabsorbed. And so these antihistamines can be active beyond their actual pharmacologic half-life. They are cleared through the cytochrome P450 system, so any patient who has hepatic impairment, it will take them longer to clear this out. Fexofenadine and cetirizine are unique in that they are also cleared renally. These antihistamines also have anticholinergic effects, so you'll see this when we look at their adverse effects. They're very similar to what you would see with anticholinergics. Commonly, they are divided up into first and second generations. That has nothing to do with their chemical classes. There's antihistamines that are piperidines that could be first generation or second generation. There's antihistamines that are alkylamines that can be first generation or second generation. So that has nothing to do with their chemical class. What it has to do with, first or second generation, is essentially how much they cross the blood-brain barrier. And if an antihistamine crosses the blood-brain barrier, it can cause somnolence. Now, that can be good because in a lot of cases we give these antihistamines, first-generation antihistamines, as a hypnotic. However, it can also be bad because if you're taking, let's say, Benadryl for your allergies and you take it at 9 o'clock in the morning, by noon, you're going to be sleepy. So somnolence can be an adverse effect or a desired effect of antihistamines, depending on why you're taking it. So the adverse effect, like I said, is somnolence, and then you can also get dry mouth, dry eyes, urinary retention, constipation. That's all fitting in with the anticholinergic effects. So remember that antihistamines, the ones that are prescribed, they do have some anticholinergic effects too. So our first generation antihistamines that you see commonly prescribed, these are not all of them, but the ones that you see commonly prescribed are diphenhydramine. This is Benadryl. You get it over the counter. It works great for allergies. Typically what I tell patients is to take Benadryl at night. So when you have your allergies, take about 8, 9 o'clock, a few hours before bed, take a Benadryl at night. Because not only is that going to help them with their allergies, but it's also going to help them sleep too. That's useful, right? You want to sleep at night. On the other hand, don't take it during the day. During the day, you take your Claritin, your second generation antihistamine, because that will not make you sleepy. So diphenhydramine or Benadryl, you can use it even if you don't want to sleep, but preferably this would be something that you would take at night because at that time then you're not going to be, the adverse effect will not be so much adverse, I guess. Okay, hydroxyzine, this is also known as Vistaril. This is not so much used for allergy. It's often used for its hypnotic effect. This is quite strong with its somnolence that comes with it. So a lot of times you'll see hydroxyzine prescribed as either an anxiolytic or as a hypnotic. Meclizine, again, this one's not so much used for allergy. Meclizine is very good with motion sickness, and it's also used as an antiemetic. So patients with vertigo, a lot of them will get meclizine. Cyproheptadine is used somewhat frequently for allergies, although this one's sort of being relegated to the dust heap now that we've got these second generations. But I still think cyproheptadine is a great prescription strength drug for just as good as diphenhydramine for allergies. So you can use that one too. Promethazine, not so much used anymore for allergies. Promethazine, though, is used as an antiemetic. You hear it, you may know this as Phenergan. It's also used as a hypnotic, and it does have some weak antipsychotic properties. So out of these, you'll probably see diphenhydramine the most because it's over the counter, but you may run into hydroxyzine and cyproheptadine as well. Okay, the second generations, these are much more popular. And they're popular for exactly the reason that I've told you a few times already, because these don't have the effect of causing somnolence. So go back here, notice what Claritin is telling you. It's non-drowsy Claritin. It's non-drowsy because it's a second generation antihistamine. So cetirizine or Zyrtec would be one example. Another one is fexofenadine or Allegra. Loratadine or Claritin, I believe, was the first one to come on the market. And I believe all of these are available over the counter now. Azelastine is available in intranasal spray. It's also available in an ophthalmic preparation. So these can be used for allergic ophthalmitis or allergic rhinitis, whereas these other ones are all pills. And they do make like children's Claritin, children's Allegra, and stuff like that. So they've got pediatric strength formulations too. Okay, how about corticosteroids? So you should know what corticosteroids are. They work in a variety of different ways at the nuclear level. They also can directly inhibit inflammatory cells. Most of the inflammatory cells, white blood cells, they have glucocorticoid receptors. And then they also mediate the effects of a lot of the cytokines and inflammatory mediators. Again, just like the antihistamines, they can be administered in a variety of ways. You can get topical preparations, you can get ophthalmic preparations, intranasal sprays, They can be administered IV, they can be administered PO, so there are lots of different ways you can administer corticosteroids. As a rule, we prefer to administer things topically or locally first before we go at administering them systemically, just because there's fewer side effects. A lot of times you'll see corticosteroids used with long-acting beta agonists for the treatment of persistent asthma. So you'll see a lot of these on TV. The combination of fluticasone, which is our steroid, and salmeterol, which is our long-acting beta agonist, is marketed as Advair. Fluticasone and vilanterol is the Breo-Ellipta. Budesonide and formoterol is Symbicort. And then you can also use some of these corticosteroids alone. So fluticasone is used alone a lot, and that's Flovent. And they also make that as an inhaler, they make it as a nasal spray. So you can get the idea here that these are all of these, for all of these drugs, as many as there are just as many ways you could administer them. And like I said, they're used topically and systemically in various allergic disorders. So not just asthma. You can use this in ophthalmitis, you can use these in rhinitis, lots of different ways you can use this. You use it topically for dermatitis. Okay, how about Theophylline? Theophylline is an ancient drug that's been used for a long time, but we don't see it as much anymore. It has been used for asthma for a long time, since probably the 1930s and 1940s. But we don't use it as much anymore because it's been primarily replaced with the bronchodilators, the beta agonists. However, theophylline is useful as adjunctive therapy in patients who don't respond to steroids, long-acting, short-acting beta agonists alone. The problem with theophylline is that there are some adverse effects that can be erratic and difficult to predict. And this can span from things as just simply bothersome, like nausea and insomnia, all the way to seizures and death. And the adverse effects are typically going to increase in severity with the plasma concentration of theophylline. So we have to monitor these patients closely if we are giving them theophylline. This is not a first-line agent. There are better medications that can be given. This is typically given as adjunctive therapy for patients who are not responding to some of the more commonly given first-line agents alone. Okay, the Antileukotrienes. So remember, the leukotriene is an inflammatory mediator. It is secreted by eosinophils and mast cells, and it works to do various things which facilitate inflammation and chemotaxis. Montelukast, zafirlukast, and pranlukast are three of the more common antileukotrienes that you'll run into. As I mentioned, they inhibit the leukotriene production, or they will inhibit leukotriene activity on the receptor site. If you're not a pharmacologist, you don't need to worry about that. Just know it inhibits leukotrienes. So by that virtue, it is anti-inflammatory. It also can diminish bronchoconstriction that's induced by exercise, cold air, aspirin, and allergens. So it does have some bronchodilatory effects as well. A lot of times you'll see antileukotrienes used adjunctively in asthma and allergic rhinitis, but it's very rarely given as its own therapy, used alone. Okay, now we're going to talk about the mast cell stabilizer. So a good thing to know about the mast cell stabilizers, it's obvious what they do. They stabilize mast cells. But remember that when you're already having an allergic reaction, those mast cells are already degranulated. So just by stabilizing the mast cells that are not degranulated yet, you haven't done anything to treat the inflammation, treat the allergy. All you're doing is preventing further degranulation of mast cells. So none of these are going to reverse the effects of allergy, but what they will do is prevent worsening of the allergic symptoms. Excuse me. So by that virtue, we do not give mast cell stabilizers to patients to treat their allergic symptoms. We give this more as a prophylaxis. The most commonly studied mast cell stabilizer is a class called the Cromates, and Cromates are cromolyn and Lodoxamide. These inhibit the degranulation of mast cells, and by doing that, it circumvents effects of various inflammatory mediators. So as I mentioned, they do not mitigate the effects of inflammatory mediators that have already been released, and they also don't have a bronchodilatory effect. So if you have a patient who's having an asthmatic attack, this is not a drug to give them. You're going to give them either epinephrine or you're going to give them albuterol. You're not going to give them a chromate or a mast cell stabilizer. However, it can be useful to give these patients with asthma cromolyn or Lodoxamide. You can give them these medications as a prophylaxis for their asthma. So it can raise their threshold and prevent an asthmatic attack before it happens. But if they're already having one, these drugs are not useful. So they're used for the prevention of allergic attacks. It's used as an alternative for mild persistent asthma in the form of a nebulizer or inhaler as a preventative measure. It's also used in allergic rhinitis and allergic conjunctivitis, which it can be given as a nasal spray or in the form of eye drops. And these are only given topically. These aren't in PO formulations, so they're only given topically. And by topically, I mean not given IV or orally. So I guess you have to look at that as a broad definition of topically. So I'm not talking about topical ointments here, although theoretically you could probably use them that way too if they have them out. But I'm talking about either inhalers or ophthalmic preparations or nasal sprays. So here you can see a nasal spray of cromolyn. Here's an inhaler, and then here's some eye drops, cromolyn. But I believe all of these are prescription. I don't think you can get these over the counter. Certainly not the inhaler. You can't get over the counter. I don't think this box for these eye drops look suspiciously like something you might get over the counter, but I don't believe you can get these over the counter. Lodoxamide is also a mast cell stabilizer. However, Lodoxamide is only available as an ophthalmic preparation, so it's very similar to cromolyn. It's a mast cell stabilizer, but it is only available as an ophthalmic preparation. It's very useful for the allergic ophthalmites, such as allergic conjunctivitis or allergic keratitis, but you will use this, this is prescription only, obviously, but you can use this in patients that are age 2 or older for these allergic ophthalmites. It has been shown to be more effective than cromolyn at alleviating these symptoms, even though it works in a very similar manner. And then Olopatadine is similar to Lodoxamide. It works in a very similar manner. The difference from Lodoxamide is that it also has antihistaminergic properties, which may make it somewhat superior to Lodoxamide. However, this is only approved for use in patients aged 3 or older, and it is available not only in the form of eye drops, but also as a nasal spray. So these two drugs can only be used in patients that are 2 years of age or older, and in the case of Olopatadine, 3 years of age or older. However, I will preface that, or suffix it, by saying that you're very rarely going to see allergic symptoms in patients a whole lot younger than that. Okay, immunotherapy is kind of our cutting edge. So we have a new drug called omalizumab, and this is a monoclonal antibody that targets IgE, free-floating IgE, which remember is useful. The immune system uses that to coat and prime mast cells and eosinophils to respond to allergens. So this is not going to bind to membrane-bound IgE. This is going to bind to IgE that is freely circulating. However, it will then prevent the priming of these cells, And so this is used for that purpose. Now, the problem with Xolair or omalizumab is a couple things. First of all, it has to be administered subcutaneously, and that can be a problem because kids are afraid of needles. But it is also problematic because it's expensive. It is presently only available as the name brand. So for that reason, it's reserved for the treatment of asthma and rhinitis that is resistant to steroids. It's got a relatively good adverse effect profile. Anaphylaxis can be encountered, but it is rare. And then there is some talk that it may be useful for food allergies as well. Now, another treatment we have in our arsenal is allergen vaccine therapy. And you will see this from time to time. These are the so-called allergy shots. And what this is they're subcutaneous injections, and this is not a one-time thing. These patients will have to come in on a weekly basis and receive these vaccines. And they're not intramuscular vaccines, not like the shots that you traditionally give. They're given subcutaneously, and what you're doing is it's almost like an exposure therapy. So you're giving gradually increasing quantities of these allergens in order to increase tolerance. The exact mechanism, however, remains unknown. What we do know about this is by giving these, if we give them to young children, it may reduce their risk of later developing asthma. And we know that children who have allergic diseases like rhinitis, they are at risk for eventually developing asthma if they haven't already. And so consequently, a lot of allergists have recommended that we give this allergen vaccine therapy, we start this earlier on rather than wait. The American Academy of Allergists and Immunologists have said that the costs of anti-allergy drugs, the ones that we've been talking about up until now, are actually greater over 5 years than the cost of this allergen vaccine therapy. And so there are some benefits to this. Nevertheless, this is primarily reserved for patients who can't achieve adequate control with avoidance and with pharmacotherapy alone. It does, of course, require formal diagnosis of a specific allergen. Since we're giving that allergen as essentially a vaccine, you need to know what the allergen is that we're going to be treating. It's effective for the treatment of stinging insect hypersensitivity, so bee stings, allergic rhinitis, and allergic conjunctivitis. However, it is not effective for atopic dermatitis, urticaria, and you certainly would not want to use it for food or antibiotic allergies, as that could trigger a life-threatening anaphylaxis. The adverse effects to allergen immunotherapy with the vaccines is a local reaction. You can get wheal flares, you can get pruritus, and that typically resolves about an hour or so, a few hours after the injection. However, when you give these vaccines, the patients are going to need to stick around for about 30 minutes or so after you administer the vaccine to make sure that there are no significant problems. And the most significant problem that could happen from this is that you could get angioedema and anaphylaxis. Rare, but it can happen. Now, there are other immunotherapies that are out there. There's a sublingual immunotherapy, and this is not approved for use, I believe, in the US yet, but it has been used in Europe. And essentially, you're doing the same thing, you're just administering it sublingually. And we've seen this used in Europe for house dust mites in particular. So that's something to keep an eye out for in the future. It is being used in Europe, though, and I believe it's still in trials here. If you have any questions, write me a note below.